to our sixth session. Today we are having the second session of our communication class. It will be taken by Dr. Biju Raghavan. Doctor, can we start with today's session?
Yes, absolutely.
Thank you, sir. So we can start with first presentation. We can have it for around 40 to 45 minutes, followed by 15 minutes of discussion. By 4, we can have our case presentation, followed by its discussion. We can wind up our session by 4:30. Thank you all for joining in. Over to Sister Shiva. Good afternoon to all. As Rajlashmi said, today we are moving on another session, another important session on communication, that is communicating bad news. I hope most of you are familiar with Dr. Biju Raghavan, who was our last week faculty. Sir, welcome back. Over to you.
Thank you, Shiva. Good to see you again after a long time. Last time it was Sunil. I wonder where he is. He's fine, I hope. Where is Sunil?
Sir, this program is facilitated by Sister Shiva, sir.
Yeah, I understand. I'm glad it is. I'm very happy to see her. I'm just inquiring. Sunil is okay. He's fine. Yeah.
He's fine.
Raj, okay. And Raj Lakshmi, it is good to see you again. And welcome all participants who are joining in from various parts of the world. It is good to have all of you over here. Excuse the small banter in the beginning because it is good to see friends. Nowadays, we can't see them in person. So when we see them on video, it is always a happy feeling. So without much ado, we can start our presentation. This is part 2 of communication. And in today's session, we are going to cover how to communicate bad news, how to manage collusion, and how to deal with anger in our professional environment. There is some background noise. I think Rajlakshmi, you need to mute.
Yes, sir, we are muting it. I request all participants to stay muted, otherwise you will be disrupting the class. Thank you. Sir, over to you, sir.
Thank you, Rajlakshmi. All right. So moving on, next slide. So essentially, when we talk about communicating bad news, across the world, we have generally two kinds of model, which is one where the person who communicates decides that I will tell everything to the patient. Remember, our session today is about communicating bad news to the patient. In many cultures, the communication is to the family and not to the patient. But in some cultures, it is to the patient only and not to the family until unless permitted by the patient. So a full disclosure model would be when a doctor or a nurse decides to disclose to the patient about what is wrong with them. And in some cultures, it is not disclosed to the patient. For example, in Indian culture, the patient is usually not told about what is the disease or what is the prognosis. Usually, it is the family which is told. Now, this happens because in some cultures, the patient's autonomy is taken very seriously. It is sacred. And in those cultures, it is conveyed to the patient, and only with the patient's permission, it is conveyed to the family. Whereas in some other cultures, the patient's autonomy is subservient or below the family's right over the patient. And in such cultures, the news is told to the family, and family decides whether the patient should know or not. And that is where the problem of collusion comes in, which we hopefully will deal today itself. Moving on, next slide. Now coming to the patients have rights too, and one of the easily recognizable right is the patient's right to know. However, equally important is the patient's right not to know. Remember, patients have the right to know, but they do not have a duty to know. What that means is if somebody doesn't want to know, we should not impose that information. Next slide. So, what should we do? Because the conflict happens if we are practicing full disclosure model and if a patient does not want to know, then what do we do? Or if we are practicing non disclosure model and if a patient wants to know, then what do we do? In both these cases, the disclosure model is in conflict with the patient's right. So that is the question. What do we do? And next slide. So what we need to understand is people are different. Everybody what their requirement is different, and hence when it comes to sharing of serious health information, when it comes to sharing of serious health information, we have to look into an individualized disclosure model. An individualized disclosure model. What does that mean? What that means is if a person wants to know, that person should be told. If a person does not want to know, that person should be allowed not to know. That information should not be imposed on that person. Coming back to the person who wants to know, we have to figure out how much the person wants to know and give the information only as much as the patient wants to know, not less, not more, but optimum of what the patient wants to know. Now, when we hear this, we might think, how is it possible? How do we find out whether somebody wants to know or not? And if somebody wants to know, then how do we find out how much the person wants to know? So, this is where the skill lies, and this is what we are going to learn today. Next slide. So, before that, before we learn how to, we have to understand some other basic things. Who should communicate bad news? So, according to you, who should communicate bad news? Just put it in the chat. The basic requirement of the person is the patient should trust that person. That is very, very important. Because if the person does not trust the person who is communicating bad news, how is he or she going to trust the information too? So it is important that the person communicating bad news should have the trust of the patient. And as healthcare providers, we must learn how to earn the trust of the patient. Secondly, we should have proper information. Now, in this case, we as doctors, nurses may have information, but that is also our handicap because we know how to convey this information only in a medical way that is full of jargon. We have to learn how to communicate in a simple way, like how a common man can understand. So, just knowing information is not good enough. We need to know how to convey it in simple language. And then the third most important part is the skill or the knowledge and the skill to communicate bad news. Next slide. So the question arises if somebody wants to know what is wrong with them, if they want to know, why should the person know it? Why should we tell it? Is there any benefit? So, some of the things that you should consider is what's on the screen. If somebody knows, if somebody wants to know, and then they come to know that their life is limited, then they get a chance to finish a lot of things that they want to finish. It could be anything related to their finance, property, will, or telling the family members instructions of the bank account, password, etc. It could be telling a family member and the children and the husband or the wife how much I love you. It is about enhancing and strengthening relationship when the quantity of life is limited. It is also an opportunity to ask forgiveness and to give forgiveness. It is also an opportunity to plan where I should get my treatment, where I should plan my funeral. All of this, a lot of planning. And then it also gives the person an opportunity to indulge in things that the person desired to. Perhaps he or she wanted to go and visit somebody, or to visit a place to see things, or to enjoy a certain type of food, anything. So it gives people a chance to finish a lot of things which were pending in their life. For example, making arrangement for children's education, or maybe preponing a marriage so that I can attend while I'm still in reasonable health, physically and mentally. Maybe 2 months down the line, I may not be able to. So all of these things happens only if the patient knows. Another thing, important thing is preventing hospital hopping and doctor shopping. What this means is if the person does not know what is going on and their expectation and reality are at two different places, then that person's reality may be at a much below level and that person's expectation may be sky high. As a result, what happens is there is no satisfaction with whatever treatment the person is getting because the person expects to get better and go back to normal life. Whereas the reality is that the person is not going to get better. In fact, it is going to deteriorate. So, when the expectation and reality mismatch happens, there is going to be dissatisfaction, and the person may seek futile treatments all over the place, going from one place to the other, consulting one doctor and the other, and wasting a lot of time, money, and resources as a result. And another problem that you have to think of is patient, but when they get overwhelmed, they have to they go and cry in the neighbor's house. But while all of these things are happening, precious time is lost for good relationships, because once the patient dies, then that is not possible. So this barrier that is created by not telling the bad news, it creates a barrier because then there is no scope for an honest emotional interaction. And this is a very big tragedy because the family members are not able, they never get a chance to hug the patient and cry. The patient also never gets a chance to say how much uh, they care for them and how much they mean to them. So an honest relationship never gets a chance. And also about total care, you are learning palliative care. You know that it is not just about physical comfort, it's also about peace of mind. The person doesn't know what is happening and is not very frustrated because things are not going according to how they had hoped for. How are they going to have peace of mind if they don't know what is happening to them? So coming to terms with what is happening to them and then achieving peace of mind, accepting it, all of these things will happen only if we tell them the bad news. And remember, we am talking about telling only to those patients who want to know. I am not saying tell it to everybody. I'm saying only to those who want to know. There are a lot of benefits of knowing the bad news. Next slide. So, how to communicate bad news? all over the world, this spikes protocol is something well known. SPIKES stands for setting up the interview, finding out the perception of the patient or what does the patient know, and obtaining the patient's invitation. Now, this is important because you have to have the patient asking, what is wrong with me? And I want to know more about it. Only then would you proceed with it. And then sharing of knowledge, giving the knowledge and information, honest and transparent information in a simple, easy to understand language. And then, of course, there will be a reaction to the bad news in the form of emotion. And we have to address the patient's emotion, allow the emotion to wait to be ventilated. And then we plan how to proceed forward. After the emotions are drained down, then you strategize and plan how to go forward. So this is in essence the spikes protocol. And then let us see how it is actually done. Next slide. So just like you do a procedure or a surgery, communicating bad news is essentially facilitating serious illness discussion. And this is like a procedure, like a surgery. It is a communication procedure. And like any procedure, there are steps to it. And the first step is, next slide. First step is pre-procedure preparation. So what you have to do is you have to read up the patient's medical records, find out how it started, where it started, and how it proceeded, and what is the present situation now, what are the options in front of us, and what are the options which are not possible, which is not feasible. So we have to be thorough in our information regarding the person. And even if you're seeing this person daily, it is very important to go through the records about their social background, personal background, education background, professional background, etc., etc. Just to just familiarize yourself because it may help during the conversation. And just like any procedure, you have to allocate a time for it. You just cannot do it as part of your routine OP uh, um, practice. You, like a surgeon will not do surgery in between OP. The surgeon allocates a time for a surgery and only then does it. Similarly, communicating bad news is a very delicate procedure. You have to allocate time. In my case, usually I do it in the late evening when my OP is over, and that time my OP area would be kind of peaceful because most of the patients would be gone. Most of the other OP doctors would be slowly winding down their activities. So usually the OP area is very calm and quiet. So that is the time when I call in the patient or the family when I have to do communicating bad news. I prefer to have a calm environment without too much noise in the corridor. And then we have to, that is how I set the environment. And then we practice active listening skills, which we learned during the previous session. Next slide. So when we start the interview, we take the patient's history and find out the patient's insight and concerns and explore if the patient wants to know. So sometimes the patient may say, what is wrong with me? Tell me, doctor, I want to know. Or sometimes you may have to ask. So we have been seeing each other for some time now, and this is the situation that we are dealing with. That your pain is under control and your appetite is improved. Is there anything that you want to know more about your medical condition? And the patient says, yes, I want to know more. Then don't straight away start telling the problem. You first give a warning shot. What exactly is a warning shot? Next slide. A warning shot is a statement or a question like this: if it is something serious, would you still want to know? If it is something serious, would you still want to know? So this is the place where those who really want to know and those who do not want to know, they get a choice. So those who are not very sure, they will not make eye contact and maybe look away from you, or they may say something like, why don't you give me my medicines, I'll come back after 1 week. Or they may change the topic, or they may tell something like, oh, you tell it to my children, or you tell it to my husband, or you tell it to my wife, or some people may say, no, no, I don't want to know. uh, I'm happy the way it is, or something like that. So if you see any of these forms of response, then do not proceed. However, if the person looks into your eyes and says, yes, I want to know, then there is no doubt that person wants to know. So, warning shot is the place where you differentiate between people who want to know and those who do not want to know. And those who do not want to know, we will not impose the information on them. And those who want to know, with them only we will proceed. So how do we proceed? We will see. Next slide. So after the warning shot is given, suddenly the environment in the room, the mood in the room changes to a serious mood. Till that time, it was a normal interview, normal conversation, and suddenly there is a tension in the air, because you said, if it is something serious, would you still want to know? And then, as a result, uh, okay, somebody's saying that the sound is not audible. I wonder if it is the case for everybody.
So we can hear it clearly. What about the rest of the participants?
All right. Okay. Right. So I assume it is audible to most people. So the person who could not listen maybe will have to check locally what is going on.
Sure, sir. I will check it. You can continue, sir.
So once the patient uh, confirms that they want to know, then we adopt a narrative approach. And what is narrative approach? It is, next slide. It is, you tell the story of the patient to the patient from the beginning. So you are basically telling a story. And while you are telling the story, you give chunks of information like fill in the blanks. So you have found out the insight of the person, and then you know that there are many areas where the patient doesn't know. And you then fill in chunks of information, and you don't tell the whole information, you give small pieces of information, which is like filling in the blank spaces. And while you are doing it, you will gradually escalate the information. For example, next slide. There would be, for example, X-ray showed something like a shadow. And to find out what the shadow was, they sent you to the city hospital. And in the city hospital, they did a CT scan. They found something like a tumor. And to find out what this tumor was, they did a biopsy. And the biopsy was taken because they were suspecting there was something like a cancer. So while you are giving each information, you focus on the body language of the patient. And what is the most important thing that you will focus on? Whether the patient is maintaining eye contact. If the person is maintaining eye contact, that means the person wants to know. At any point in time of your storytelling, you are telling the story of the patient and you are filling in the blanks with chunks of information. At any point of time, if the patient stops making eye contact, is not looking at you, you stop the story there. You pause, you push the pause button, and you stop the story there. Wait, because this new information may be something that the patient did not expect. So the patient is processing this new information, is trying to it. He has heard it, he has swallowed it. Now he is trying to digest the new information, and it may take some time. So what you to remember is that we are not setting the speed of the interview. The patient decides the speed of the interview. The patient decides when the interview will stop. The patient decides how much information will be shared in the interview. It is essentially a patient centric facilitation of information. And in case the pause is getting very long and you are confused, what should I do now? Then you can ask the person, should I proceed? Do you want to know more? And if that person again looks into your eyes and says, yes, I want to know more, then there is no confusion, you can proceed. If the person does not respond or make some vague statement or gives some another excuse or says, oh no, let's stop here, then do not proceed. That means the patient had enough. So, whenever the patient had enough, you stop the sharing of information there. You continue the story. Next slide. So once the full information is shared or enough information is shared, whichever is whatever has happened. For example, if the patient does not want to know beyond tumor, or if the patient heard everything about cancer and it has spread and all of that, in that point of view, excuse me, Lakshmi, I think I have a call. Can I take it a minute, please?
Sure, sir.
Yeah, I think I can proceed. So, yeah. So, if we have to, uh, where was I? Yeah. So, wherever the story has finished, stopped, either at full information or enough information for the patient, be prepared for an emotional reaction to the bad news. The emotional reaction can be in the form of tears, crying, or it can be in the form of anger. Why didn't they tell me? So my family hid it from me. It could be anger. Whatever the emotion it may be, now it is your time to keep quiet and allow the person to ventilate. Next story. Next slide. So this is the next most important thing that I want you to remember. When the patient is can you go back please? When the patient is ventilating emotion, don't say something, don't do something, just be with the patient. Don't say something, don't do something, just be with the patient. And if you find it appropriate, you can touch the person in a appropriate way for a moment. Don't continue touching the person, just touch the person on the shoulder or on the hand somewhere, and after a moment leave the hand and be with the person. And the person may ventilate the emotion in the form of crying, or they may say a lot of words about many things. So allow them to ventilate. If they are getting angry, allow them to say whatever they want to say in anger. Or sometimes they may just say, I always knew it, I suspected it. Thank you for telling me. So the responses can be very different. It will be different from person to person. So whatever is the response, you have to allow it to come out. Because when one hears a bad news, there's a sudden spike of high emotional stress. And that point of time, if you tell the plans of the future and what can be done, none of those information is going to go inside. So it is important for the emotion to come down. Only then the further discussion should be done. Next slide. So once the emotion has subsided, then ask if the patient would like to know more about what is to be done, etc. Sometimes the patient may ask, so now what is to be done? Is there how much time do I have, etc., etc. So whatever the questions comes, give an honest and clear answer. If you don't know the answer, be honest about it, that I don't know about it. But don't leave it there. You say, I'll try to find out from somebody, or I'll direct it to somebody. Sometimes there may be existential pain. What did I do to deserve this, doctor? Why is God being so cruel on me, or words, or something like that? Obviously, uh, you will not have a clear answer to that. It is very important to just stay silent and be with the person. For answers that you don't have, be silent and be there, because listening, active listening, is also a therapy. It is healing to the person. Next slide. Do not give false hopes. This is something that we talked about, the do's and don'ts last time. But do give achievable hope. So many times I tell the patient and the family, see, the disease is progressing, so nothing much can be done about it. The weakness will improve. The weakness will only grow. However, I'll make sure that you do not suffer. I'll make sure that you do not have any pain. So these are the things that you can actually do. We can make sure that they don't suffer in pain or breathlessness or restlessness, etc. So those achievable hopes we must always give, and then give them a clear cut plan. These are the medicines I am giving, and we will meet after 2 weeks. Or if you find it difficult to travel, you can send somebody over to my OP, etc., etc. And these days now we are also providing telemedicine facility, so I give them that option also. But it's not necessary that you need to have telemedicine. You can have telemedicine without telemedicine. Next slide. Ask for any clarification or any doubts that the patient or family may still have. And once that is there, close the interview by leaving the door open. And what does that mean? Even you're closing the interview, you can tell them, in case you have any doubts, or if you want to reach out to me, here is a number. If you don't want to give your personal number, don't give your personal number, but give them some number, the hospital number, the clinic number, your department number, or anybody. So that in case they want to reach out, there is some number that they can have. Next slide. So post procedure follow up. So visit or call the patient before the day is over. So it's not necessary that you yourself have to do it. You can delegate this work to somebody else, but make sure that the patient is either visited or gets a call before the day is over. Can just say, I just wanted to see how you are doing, if you have any more questions. So anything. So you're just making sure that they are fine, or if they have any questions, etc. Because it is possible that the patient and family may need some other uh, clarification, or may need some other validation of their emotion. So all of these things, it's important. A post procedure follow. So there's a pre procedure planning, and there's a step by step procedure. The most important part is we do a warning. We give a warning shot, and only then proceed. Only to those people who want to know, and never to those who do not want to know. And for those who want to know, we tell them a story, a narrative approach, uh, tell them the patient story from the beginning, and then we fill in the blanks as we go along, gradually escalate the information, and then we stop where the patient wants to stop. And then we allow ventilation. And when ventilation, emotions are being ventilated, don't say something, don't do something, just be there with the person. And once the emotion comes down, then talk about what can be done, what cannot be done, make a plan, and then close the interview. And post procedure follow up, just give them a call, or just make a short visit, uh, and then that is how we finish communicating bad news. Essentially, what we have to understand, it is, we do not break bad news. It is not a violent procedure. It is communicating bad news. It is a very gentle sharing of information. It is facilitating serious health information. It's a very, very gentle procedure. And now you know how to communicate bad news.
Hello, Dr. Biju. Dr. Biju. Hello, sir.
How it is done.
So we have lost you in between.
After communicating bad news, you once the patient and family leaves, then before you wind up your day, either you, if the patient is in the IP, either you can go and visit them before you go home, or you can arrange for somebody to visit them, somebody from your team to visit them. Or if they have gone home, because if the procedure was done on an OP basis, then either you can give them a call, or you can arrange one of your team members to give them a call, just to find out how they are doing. So that is the basic post procedure follow, right? So that is how we finish communicating bad news. Now coming to the next topic, collusion. Many a times, what we see, the family member comes to us and says, please do not tell this bad news to the patient, and they request us. Basically, what they are trying to do is they want to enter into a conspiracy of silence. The conspiracy of silence is that the family requests that whatever information is to be shared between the medical professional and the family, this should not be conveyed to the patient. So that is collusion. So this is something very common that we see in India, and as a result, we find it very difficult to communicate bad news to the patient, because most of the time the family does not want us to communicate bad news to the patient. So a few words about this. Next slide. So why does this happen? This happens because family is trying to protect their loved ones from harm, the harm of being exposed to bad news. And where is the source of the bad news? Us, healthcare professionals, because we are the ones who have the information. So the family is afraid we may tell the bad news to the patient, and they come to us and says, please do not tell it to the patient, because the family is trying to protect their loved ones. Next slide. So the most important thing in collusion management is forget the patient. Forget the patient. Right now, we have to deal with the family. So forget the patient, deal with the family, acknowledge that the family is afraid. Acknowledge, that is, you have to understand that the family is afraid, family is very anxious. So we have to make sure that the family's anxiety, family's fear is brought down. So first and foremost is you have to acknowledge within your heart that the family is afraid, family is afraid of you. Next slide. Next thing to do is do not challenge their belief. Their belief may be that the moment you tell the bad news to the patient is going to die. You know that doesn't happen. And now you have learned how to communicate bad news only to those patients who wants to know, in a very gentle way. It is essentially facilitating serious health discussion. However, the family does not know that. Their belief is the moment you say that the person has got cancer, the person is going to stop eating, is going to go into depression and may commit suicide, or is going to die of a heart attack. Whatever be their belief, do not make fun of their belief, do not challenge their belief, do not say no, what, this is wrong, you're totally mistaken, this is not how it happened. Because when they believe it, you telling it doesn't happen doesn't make any change. So do not challenge their belief, do not make fun of their belief. Next slide. What you have to do is agree. Okay, if this is how you feel, okay, we will not tell it. I will not tell it to the patient. So the moment you agree, their anxiety and their fear will come down. It will not go away because they still don't trust you fully, but at least a major part of it will come down. And how are you going to earn their trust? by actually not telling the patient. So what you will do instead is you will provide physical comfort to the patient by assessing the patient's problem, finding out what are the problems, and along with it, you will also provide medicines to take care of patients' pain, constipation, breathlessness, irritability, low mood, anxiety, insomnia, etc., etc. So, overall, with these measures, the patient will start feeling better, and with this, the family will start trusting you because you agreed not to tell and you kept your word. You promised you will not tell and you kept your word. You did not tell it to the patient. In fact, you made the patient better with your medicines. So this will earn the trust of the patient's family. They will start believing the entire team, the doctors, nurses, physiotherapists, dietitian, everybody. They will say, oh, these people are good. They keep their word. They are getting my loved one better. Even though I know the disease is advanced, disease is serious, still they are doing the best for my loved one. So this is how you earn the trust of the family. Next slide. And once you have the trust of the family, then you work with them, you cater to the, you listen to what they have to say, and you know this is how you earn the trust of the family. Next slide. And once you have the trust of the family, then you can start telling about the importance of communicating bad news, about preventing hospital hopping, doctor shopping, the expectation reality mismatch, and as a result, how the patient can lose faith uh, in a treating system, and a chance to finish whatever they have to finish in their life, and how a transparency within the household can improve relationships, etc., etc. So these points you can bring in at a later stage, and once the family understands, yes, it is important, then you can offer to communicate bad news to the patient. And while you do it, also tell them, I will only tell if the patient wants to know. If the patient does not want to know, I will not force the information. I will only tell if the patient wants to know. So with the permission of the family, by managing collusion, taking care of collusion, with the permission of the family, you can proceed to communicate bad news. Next slide. So sometimes it is possible that despite your best efforts, the family may not be convinced. So in that kind of situation, please do not push your agenda, because you should not have an agenda. It is possible that the patient may be asking you what is wrong with me, and of course you can't tell the truth because you don't have the permission from the family. In that kind of situation, try what you can do is physically best for the patient, and sometimes you may have to tell the patient that I need to know more information, I am still gathering more information, and you can try working with the family to see whether they are willing for you to mm, communicate bad news to the patient. And one thing that I can tell you is that the more you practice communication skills and the better you become, the you will get better outcome. So in the initial stage of my career, it was much more difficult to convince the family, but gradually I have realized that I have to work with the family based on how they are, because every just like every patient is different, every person is different, every family is different. So with some experience and your ability to manage collusion improves. But whatever it is, however skilled you are, however experienced you are, there will still be many families who will resist this idea of telling the patient, and that is fine. We will accept it, and if that is the case, we will continue working with the family to do the best that is possible for the patient. Next slide. So now we are coming to the last topic, which is anger. Anger is a high energy consuming negative emotion. Now, this definition is very important. It is high energy consuming negative emotion. So if it needs a lot of fuel, because it consumes a lot of energy. So if you cut off the fuel supply, you can easily manage it. So the whole idea is to figure out how to cut off the fuel supply. The important thing to realize is nobody gets up in the morning and says, today I'm going to get angry. Nobody gets up from the bed and plans like that. It just happens because all through the day we are exposed to a lot of stress, and especially if we are sick, if we are in pain, we are suffering, the emotional stress builds up, and at some point of time it just bursts out. So when people are emotionally stressed out, either they cry or they get angry. And this is essentially the basic reason is the same: stress, emotional stress. So if we feel sympathy for somebody who's crying, maybe we can try feeling sympathy for somebody who's getting angry. Maybe it's a little difficult, but think about it. If somebody is crying, we feel, oh, you feel sorry for the person, you try to help that person. Same thing applies to anger also. Next slide. So what is important is anger is an emotion. It consumes a lot of energy, and how to cut off the fuel supply, how to facilitate anger to flow away. So when somebody is very angry, there's a lot of adrenaline rush, and as a result, the person is not able to sit down. So a very angry person is usually somebody who's standing with the jaw clenched and the fist clenched, ready to fight. That is the classic posture of somebody who's getting very angry. So telling that person to kindly sit down will only make the person more angry. Telling that person that you know you are wrong, you cannot shout here, will only make the person more angry. Trying to make excuse to an angry person will make the person more angry. Trying to reason with the person will make the person more angry. Ignoring that person will make the person more angry. So if you confront the person in any way, in the form of trying to calm the person down, or trying to argue with the person, or trying to find or trying to make excuses or explanation, all of this are potentially can make the person more angry. And if you ignore the person, let the person talk whatever he or she wants, and if you ignore it, that also can make the person more angry. So what is to be done? Don't confront, don't ignore. So how do we do it? So body language here also is very important. So when somebody is standing up, we also stand up, because the two bodies have to be equal, because in communication equal positioning is very important. It shows respect. So stand and listen. If somebody is getting very angry and you are sitting down, if you remain sitting down, that alone will make the person more angry. So just stand up and listen. And how do you do that? You, you bend the spine a little bit forward. Like if you're sitting, the first the we talked about last session, our body position and body posture. So if we are sitting or standing, in the beginning of any conversation, we slightly bend our spine forward. It shows that I am listening to you, and that shows I am not a threat to you. I am not going to attack you. So a slightly bent spine shows respect and telling the person, I am not a threat to you. Secondly, you maintain eye contact, which shows that I am not scared of you either. So it is a good mix of respectfulness and confidence. And this mix is important to deal with a person who is angry. So stand and listen, slightly bend forward with eye contact and shake your head. And you can say, "Mhm," and shake your head. Do not say anything. Do not make any explanation. Do not make any excuse. Do not argue. Do nothing. Just stand, listen with your spine bent forward and eye contact, shaking your head. And this will allow the person to ventilate the anger. And since there is no confrontation and no ignoring, the level of anger will suddenly come down very shortly. In a very short span of time, the serious anger comes down. The anger does not go away completely, but a major part of the anger comes down. And once the person is visibly calmed down, once the person is visibly calmed down, then uh, then request the person then request the person, or rather then invite the person to sit down. You can say, "I want to know more about it. Can we sit down and talk about this?" It is at that point of time you will invite the person to sit down and talk. And once the person sit down, don't say anything much. Allow the person to ventilate more. Allow the person to talk more. So the simple solution is allow the person to talk, complain, 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 and then gradually the anger will go. And once the person seemed to be in a position where he is able to have a normal conversation, only then, if you by this time you would have understood what is exactly the problem. And many a times, one the patient or the person was getting angry. Once they ventilated, they don't want a solution. They are happy, they are at peace, and they may say, "I'm sorry I made such a big fuss." They may go away with that. But if there is something that needs to be done, needs to be corrected, at that is the point of time you can talk about what can be done and what cannot be done. And in case you don't have an answer, you can then at that point of time call in somebody who may have an answer to the patient's grievances, for a solution to it. And if there is no solution, then you can just apologize and say, "Okay, this is the situation. We'll make sure that doesn't happen again." At that point of time, an apology is fine, but not in the beginning part. First, understand what is the problem and get the tempers down. Only then, if there is anything that can be corrected, do it. If there is nothing that can be corrected, that possibly can be done, then just simply apologize. And remember, this technique is fine when we are dealing with one person or one or two-person, but this is not something that I would recommend if there's a big mob of violent people. Then you have to run away, and because that is no longer an anger problem, it is a law and order problem. Similarly, this will not work for somebody who's under the influence of alcohol or other drugs, because and you cannot reason with somebody under the influence. So you can only have a reasonable conversation with somebody who is sane, who is willing to listen, and is only angry. You allow the ventilation to happen, and once the anger comes down, then you have a conversation. This is not possible with a mob. This is not possible with somebody who is under the influence. So don't think that this is something you will do in every situation. You will not do this in a law and order problem. You will only do it in a clinical environment where anger can potentially get out of hand. So this is how you will manage anger. And if you have any questions regarding communicating bad news, collusion, or anger, I'll be happy to take them. Next slide. Okay, I think this is the last one. You have to take care of yourself, because you can also get very angry. And this is where the self care comes in. So, in our work environment, find a friend who will spot anger in you. And you can take turns in spotting anger in the other person. So, how do you spot anger? If the person, your spotter, has to be a good friend, an honest person who will tell you, "Hey, your voice volume is going up. I think you're getting angry." Or, "Hey, you're being too sarcastic in your comments with people. I think you are getting angry. Hey, you're using little strong words. I think you are getting angry. So it is very important for your spotter friend to be honest in the critique, and for you to take it in the right spirit, because this will prevent you from exploding into an anger. Because when you explode in anger, you don't even know that you are getting angry. So only when the anger builds up and then it suddenly explodes. And when it explodes, then there is nothing much you can do about it, because angry words that come out of your mouth, then many a times that you can never take back. And if your friends and colleagues are extremely nice, they will forgive you, but many a times it may not happen. And personally, I've been very fortunate that sometimes I've exploded in anger, and I'm glad my colleagues, uh, one of them is sitting there and they have always forgiven me, and I'm extremely glad about it. But it's important that you have friends, colleagues, who will tell you, who will spot anger building up in you in the beginning stage itself and tell you that I think you're getting angry. And when somebody tells you, I think you're getting angry, it will give you a chance to self realize and then calm down. That is best way to help each other not get very angry and stressed out. I think that is the last slide. I'll stop here. It is 4 o'clock. Yeah, that is the slide. I'll be happy to take any questions, if any, or maybe we can proceed with the next part. I think maybe we can proceed with the uh, case discussion.
Yes, sir. So today's patient story will be presented by Mr. Vimlesh Pandey. Over to you.
Hello?
Yes, yes, we can hear you.
Okay. Good evening to all.
Hello?
Hello?
Yes,
Am I
yes, we can hear you.
okay? Good evening to all. A small introduction about myself. My name is Vimlesh Pandey from UP, working in Broadwell Christian Hospital, Fatehpur. I joined in palliative care in month of September as a palliative care team member. So, coming to the patient details, a 47 years old male patient with diagnosis of carcinoma of lung. Next slide, please. Presenting complaints is ulcer all over the tongue since September 2019, and pain scale was 9, weakness and fatigue, difficulty in chewing and swallowing, loss of appetite. He is also having insomnia, difficulty in sleeping, constipation. Next slide. Coming to history of illness, it started with ulcer over the tongue with mild pain. And then he was started taking some painkiller from medical store like diclofenac and paracetamol. And he went to cancer hospital Kanpur, and there he was diagnosed as a cancer of tongue. And and then he led treatment there and went to Banaras for Ayurvedic treatment due to some socio-economic condition and what they believe and all. And and then one began to enlarge with increasing pain and salivation. Toothache also is there. Next slide. Examination. Ulcer started growing bigger all over the tongue with policemen. Tenderness on palpation. Swelling over the face and side of the neck. Moderate anemia also present. By knowing his SB level, it was 8.6 gram percentage. Hypothermia also present tachycardia, hemoptysis, and oral infection. Treatment and significant investigation was started with injection tranexamic acid and ethanol due to bleeding, and tramadol 100 mg every 4 hourly. When he did not get relief with tramadol, we started injection nalbuphine 0.5 ml when pain getting worse, and antibiotic also started after investigation. Betadine mouth was added for oral hygiene. And when he didn't get relief with injection nalbuphine and tramadol, then doctor started applying buprenorphine pipes because we don't have morphine in our hospital. That's why we started buprenorphine pipes. And injection iron sucrose to treat anemia, antipyretic to treat the hypothermia, 5-amitriptyline to decrease salivation, injection ondansetron for nausea and vomiting, chest X-ray, and blood investigation also done, CVC with differential and BPCT. He was on rise to feeding. Next slide. Coming to psychosocial aspect, he is getting anxious due to his illness, and he was worried about his illness, frustration also, and he was denied for his treatment due to poor socioeconomic condition. Next slide, please. Medication, tramadol 100 mg every 4 hourly, injection nalbuphine 5 mg every 6 hourly, injection tranexamic acid every 8 hourly, injection ceftriaxone 1 gram every 12 hourly, injection metronidazole 500 mg, injection metronidazole 500 mg every 8 hourly, fluconazole 150 mg every 12 hourly, 5-amitriptyline 50 mg every 12 hourly, injection ranitidine every 12 hourly, and betadine mouthwash. Next slide, please. And coming to main concern, his main concern is whether he will cure or not, and how long he had to be on medication. And he was also worried and getting anxious and worried about his children, who will support his children and marry his daughter after him, because he's the only one who had to support his family. That's why he was worried. Next slide. Subways, a 47 years old patient had a small ulcer over his tongue. This progressed all over his tongue and mouth in a period of 4 months. He is diagnosed as tongue cancer and referred for treatment, but he refused that and started Ayurvedic treatment instead of modern medicine. Our palliative care team managed to help to reduce pain with analgesia and also to get peace in his heart by providing hello, and also to get peace in his heart by providing psychological and spiritual support. Okay. Discussion point is, how can we manage denial of treatment? Second is, how to improve nutritional intake for patients with extreme pain in the mouth. Third is, how to treat candidiasis. Fourth is, how do we communicate the diagnosis of cancer to the patient and family. And next is, how can we help patients cope up with the denial of diagnosis and get started on treatment. Next slide. Thank you.
Thank you, Sister Vimlesh Pandey. So anybody would like to need any more clarification regarding this patient story, please ask. Otherwise, we will move on to the discussion points.
I have one doubt. First of all, Mr. Vimlesh Pandey, thank you for that excellent case presentation. Very informative, very well. The story came out very well. So congratulations for that. And since you're so young in palliative care, only started in September, so this is very good presentation. I just wanted to know regarding the medication that you showed about. It's written tramadol 100 milligram 4th hourly.
Yes, sir.
Uh, well, uh, Are you sure it is 100 milligram and not 50 milligram?
Its type was 50 milligram, but we are giving two type at one time.
Yeah, because tramadol at very high doses.
Yeah.
For example, the maximum recommended daily dose is 400 milligram. So problem with this is 600 milligram per day. So problem with high doses of tramadol is it lowers the seizure threshold. And at high doses of tramadol, people can get seizures. So we have to be very, very careful
Yes.
regarding the dose of tramadol. Also, if the liver function is compromised, then definitely even low doses of tramadol can be a problem. I don't know whether the LFT was done, liver function test was done here.
No,
So
sir,
that
not
was,
yet.
yeah, because if the liver function is compromised, then we can't even give normal values of tramadol.
Yes, sir.
So that was the only thing that came into my mind. The tramadol 100 milligram 4th hourly seems to be a little too high.
Okay, sir.
Okay,
We'll keep.
right.
Okay, sir. We'll
Okay,
keep in mind for the next question
okay.
another.
Thank you, thank you, thank
Thank
you.
you, sir.
Sir, can we move on to the discussion points?
Yes, please.
So, first question, how can we manage denial of treatment? So, we would like to hear from the participants. You can either chat your opinion or unmute yourself and speak.
There seems to be a ghostly silence.
Hello.
Yeah.
Yeah. Yeah. What I wanted to say was, if a person is not willing for treatment, all that we can do is we can just try and convince them. Every visit that we make, we can only try and talk to them and convince them. But the decision is in their hands. We can try to influence using people who they are close to. Maybe somebody in their family, or maybe even some religious leaders to whom they look up to. We can maybe talk to them through such people and maybe try to convince them. So that is one option that I can think of.
So,
That's very well said. I have no idea who said that.
Daniel Francis have commented, sir.
Okay, that is great, Daniel. That is exactly what I would also do. Essentially, denial per se uh, uh, is okay because many times it is the only coping mechanism when one is dealing with severe emotional distress. However, if we are dealing with denial becoming a barrier to treatment, then only denial needs to be broken. And then, as Daniel said, we have to try ourselves and also take the help of the patient's near and dear ones, and maybe even uh, other people, either professional psychologists or spiritual people. Yeah. If there are any comments regarding that, uh, please put it in. Daniel has actually given a very good answer. So yeah.
So, we have 2-3 comments also. It is there in the chat, sir. Dr. Biju? So, how to improve nutritional intake for patient with extreme pain in the mouth? Next question.
Yeah.
So, any comment on this?
I guess you can
Right.
ask the participants
Yes,
to
yes.
write their comments as chats so that we can see them, and both of you can read out from the chat box.
Using nasogastric tube, we can put nasogastric tube again. Cold soft diet.
Yeah, those are good suggestions. What is HCCM? What is HCCM? Yeah, Regina is saying that we must manage pain. Yeah, absolutely. If what with the resources that we have, if the pain is not getting controlled, then perhaps we can think in terms of referring the patient to a higher center where pain management can be done more effectively. Or if you are already working in a multi-specialty center, you could ask other colleagues to help out with the pain. For example, not particularly for the mouth pain and the tongue pain of this particular person, but many of the bone pain due to metastasis, the best thing to do is to give palliative radiation. It works better than any of our analgesics. So palliative radiation will not only reduce the bone pain, it will provide a lot of strength also to the bone. So the chances of fracture also comes down. Pathological fracture also comes down. So there are many other ways of reducing pain. It is not only our pain medications. Uh, for example, I have one patient who has metastatic carcinoma breast. It came on the right side. That breast was removed. Total mastectomy was done, and then subsequently it has come to the left side. The left side is the breast is totally involved. It is like one full rock there, and then she has multiple bone metastasis. She has a fracture of the right thigh bone and fracture of both arm bone, humerus, and now she is bedridden. So what surgery cannot be done. So what they have done is that the physiotherapist has arranged for what do you call this one immobilization sleeve. It's a plastic sleeve. It causes immobilization so that the movement of the both arm is now restricted, and because the movement is restricted, the pain has come down. So there are many things that can be done. It is not only medicine. When you think of pain management, don't think only of medicine. There are many other things that can be thought of. And yes, for pain, definitely for the mouth, definitely all the things that you have talked about, pain medicines, nasogastric tube, etc. The other thing that you can think of is local anesthetic. We can we have xylocaine, we have lignocaine in the form of viscous, and we also have lignocaine in the form of spray. So all of these things can also be considered because it will provide numbness, and will and while the numbness lasts, the person can swallow food. So nutrition can be taken care of that way also.
So another thing, I think there is a oral candidiasis present in the mouth. The patient experience
How to
swallowing
treat
difficulty.
candidiasis?
Yes,
Okay.
if there is a oral candidiasis present, especially in the lower esophagus, the patients experience dysphagia.
Right, right.
So maybe we can
Or
assess for
dynaphagia
that.
also.
Yes.
So the next question is how to treat candidiasis.
Candidiasis.
Would somebody high calorie cereals milk? Okay, HCCM. So yeah, I learned something new today. Thank you, Rashmi Pandey, for that. High calorie cereal milk. I had no idea that something like that existed. I'll have to Google it and find out. So treatment of candidiasis is fairly simple. You use any of this antifungal medication. You can use fluconazole, for example. It is fairly cheap. It has been used for decades, and you can, if there's a lot of candida, yeah, nystatin oral drops. Then we have candid mouth paint. There's a lot of options for treating candidiasis, and as Shiba said many a times, esophageal candidiasis that usually we can't see could also be a cause of painful swallowing or dynaphagia, which also leads to difficulty in swallowing, which is dysphagia. Okay, so if Rajlakshmi and Shiba would excuse me, may I leave the today's webinar and proceed with my work?
Yeah. Yes,
Is
sir.
that okay? Right.
Thank you,
I
sir.
think we have covered most of the discussion points.
Okay.
Okay. Thank you everybody for having me. Have a great time with this course, and I'm sure a lot of patients and their families are going to benefit from your efforts in doing this course. Thank you so much. Thank you, Pallium India, for arranging this. Bye
Thank you,
bye.
sir. Thank you, sir, for the excellent presentation. Thank you.
It's always a pleasure, Shiba.
Okay.
Bye. Bye. Thank you so much. Thank you, everybody, for the nice comments you're putting in. Thank you. Bye bye.
Bye, sir.
Bye.
We already discussed the last two points. How do we communicate the diagnosis of cancer to the patient and family? We already discussed. If you have any doubts on that, we will discuss again. So we know patient have right to know the diagnosis. So we we need to give an idea about his or her diagnosis, but you can do it in a proper way. Otherwise, that will be harmful for the patient and the family also. So the breaking bad news is the stressful situation for both the medical professionals and as well as the patient and their family. So if you have any stressful situation like as a medical professionals like us, if you have you can aware of that. If you have any that stressful situation there, you just to share your emotions with your best friends or best colleagues, so that that is a self care, so that you can you can able to stress relief from that, you can able to some relief from the stress. And for the patient side, after the breaking bad news, again the patient and family also the stressful situations. As the nurses, we are able to give a psychosocial support, psychological support. If possible, be with the patient and give a psychological support for the patient and their family. So When you break the bad news, you can always, as Sir said, you can use a spike protocol for that. So if you need any more clarification on that, we will discuss again. Any doubts regarding breaking bad news or collusion? So and another thing is collusion. If the patients, if there is any collusion there, so we know that patient should know the diagnosis, but at the same time we respect the patient's, the caregiver's concern also. So we need to understand the importance of knowing the diagnosis the patient with the relatives, the caregivers first, and you have to just share what are the benefits and the non-benefits, so that they will understand well, and with the caregiver support we can able to that break the bad news to the patient. I think this patient is having rides to feeding, rides to, is it correct? The patient, this patient is on RT feeding.
Hello, ma'am.
Yeah, this
Yeah, it's rice tube feeding.
rides to. What are the important things we need to do, or that the patient is on rides to feeding? What important instructions? I would like to hear from the participants. What important instructions would you give to the patient family about RT feeding? Any points? Position? Very good. Then you have to aspirate the food contents. You have to make sure whether it is the rice to be in the stomach or not. Then semi-foulers, okay. Okay. Anything else? So when we introduce a rice tube, what happened? So when we introduce the rice tube, there is a sphincter between the esophagus and the stomach, no? So it's the gastroesophageal sphincter is always open when you introduce a the rice tube. So what happened if you're that feeding more quantity you fed at the time, that sometimes the frequency, the feeding frequency, the frequency is too short. Every hourly 200 ml or 300 ml, 500 ml you give. What happened after after feeding, the patients will regurgitate. That fluid regurgitate is that goes to trachea, and the patients, the complication is aspiration pneumonia is there. So the most common complication is aspiration pneumonia for a rice tube patient. So make sure that the position after feeding also, they need to keep the same position at least an hour. Otherwise, the regurgitation is the problem. Sorry, we have lost you in between. Maintain personal hygiene is also important. And another thing is they can use the homely food, homely available food. They can grind it well and give through the rice tube. That
the simple things you can tell the patient and their family for the rise to feed patients, and the importance of that sticking the micropore on the nose. So the another problem, you have to change the sticks, the micropore in between. Otherwise, that frequently you have to change the place also. You can either stick it on their cheek, either right side cheek or left side cheek. Not always stick on that on the nose. So these important things you can keep it to in your mind. Thank you all. If you have any doubts, please ask us through your WhatsApps. Thank you, sister, for the excellent patient story. Okay, thank you.
Thank you all. We can see you on next Tuesday with another topic. Then bye. See you later.